Rural healthcare access in the United States has deteriorated dramatically in recent decades, with hospital closures, physician shortages, and specialist scarcity creating genuine medical deserts. In this context, AI assistance has emerged as an informational resource for rural populations, but we must examine this development with clear eyes about both its benefits and its inadequacy as a solution to systemic problems. The access barriers facing rural populations are severe and multifaceted. Travel distances to medical facilities can be enormous, requiring hours of driving for appointments. This is particularly burdensome for elderly people, those without reliable transportation, and individuals with medical conditions that make travel difficult. Specialist care is often completely unavailable locally, requiring travel to urban centers that might be hundreds of miles away. Rural hospitals have closed at an alarming rate, leaving some areas with no nearby emergency services at all. In this context, AI providing basic health information and guidance becomes genuinely valuable as a partial mitigation. Someone living in an area with poor medical access can at least get preliminary information about symptoms, learn about potential conditions, and receive guidance about whether their situation requires traveling to seek care. This is meaningful when the alternative might be complete information vacuum or long delays before accessing any medical input. AI can help rural patients prepare for the medical appointments they do access, making those appointments more efficient and productive. When you have to drive 3 hours to see a specialist, arriving with organized symptom history, relevant questions, and understanding of your condition maximizes the value of that visit. AI can assist with this preparation in ways that weren't previously available. Telemedicine integration offers another potential benefit. Rural clinics might have limited on-site expertise, but could use AI-assisted systems to help with patient education, symptom documentation, and preliminary assessment before or between telehealth consultations with specialists located elsewhere. This extends the effectiveness of remote medical care. However, we need to confront the harsh reality that AI as a response to rural healthcare gaps is profoundly inadequate and potentially dangerous as a long-term solution. Rural populations need actual medical care, physical examinations, diagnostic testing, procedures, emergency interventions. AI cannot provide any of this. Positioning AI as a solution to rural healthcare access normalizes abandonment of these communities by the medical system. Infrastructure limitations undermine AI's utility in precisely the areas where it's most needed. Rural areas often have poor broadband internet access or no internet access at all. Mobile networks may be unreliable or non-existent. The devices required to effectively use AI tools might be unaffordable for many rural residents. Elderly populations, who have disproportionate medical needs and are overrepresented in rural areas, may lack the technological literacy to effectively use AI tools even if infrastructure exists. Cultural factors affect adoption in ways that pure technological solutions ignore. Rural communities often have different relationships with technology and healthcare than urban populations. Trust in medical advice from a computer program might be lower. Preferences for relationship-based care with known local providers might make AI consultations feel impersonal and unsatisfying. These cultural contexts matter for whether technological solutions actually get used and whether they provide value even when available. The risk of two-tier healthcare systems is acute. If policymakers and healthcare administrators decide that rural areas can make do with AI assistance while urban areas have abundant human medical care, we've institutionalized healthcare inequality based on geography. This would be morally unacceptable and practically disastrous, as AI cannot substitute for the full range of medical services that every population needs regardless of location. Proposed hybrid models offer more promise than pure AI solutions. Local clinics providing basic physical examinations, vital sign monitoring, point-of-care testing, and routine care while using AI to supplement education and follow-up could extend limited rural medical capacity more effectively. Community health workers trained to use AI tools as decision supports while providing human connection and clinical observation could serve rural areas more effectively than either humans or AI alone. Mobile clinic programs that combine periodic in-person care with AI-assisted remote monitoring and education between visits could provide continuity, while acknowledging that some medical services require physical presence. Emergency medical services using AI-assisted protocols for triage and initial treatment while arranging transport to facilities could improve outcomes in rural medical emergencies. Critically, all of these approaches require investment in rural infrastructure, broadband expansion, medical facility maintenance and development, training and support for rural healthcare workers, and financial incentives for medical professionals to practice in rural areas. AI cannot substitute for these investments, it can only supplement them. Using AI as an excuse to avoid making necessary investments in rural healthcare infrastructure would be a profound policy failure. The fundamental principle must be that rural Americans deserve the same quality of medical care as urban Americans, and that quality requires human medical professionals, appropriate facilities, and adequate infrastructure. AI can be a useful supplement that helps extend limited rural medical capacity, but it's an unconscionable substitute for actual healthcare investment in rural communities.